Shiba, we're coming to you.
Yeah. Can you see us?
Yes, we can, and we can hear you.
Well, we have a patient who had many interventions in the past, including a fenestrated fontan surgery. We'd like to give you a case. Dr. Ravindra, can you tell the clinical story?
Yeah. Dr. Ronak here from Madras Medical Mission Hospital. I'll be taking you through the summary of this case. We have a 13-year-old child. His native anatomy was he had a univentricular heart with pulmonary atresia, with confluent pulmonary arteries, left aortic arch, and an aberrant right subclavian artery. The ductus arising from the aberrant right subclavian artery was supplying the confluent PAs, with a large descending aortic collateral to the left lower lobe of the lung. In infancy, he was intensely cyanotic because of the stenotic PDA, and he underwent PDA stenting. At 2 years of age, he underwent coil closure of the left lower lobe MAPCAs, followed by right bidirectional Glenn shunt and PDA ligation. At 6 years of age, when he was evaluated for completion of fontan, he was found to have developed a large levoatriocardinal decompressing channel, which was closed using a PDA device. Subsequently, at 8 years of age, on evaluation, his PA pressures were found to be high, 20 millimeters mercury, due to residual flows through the left lower lobe MAPCA, and subsequently they were addressed with coil embolization. At 9 years of age, he underwent another cath to assess the feasibility of fontan completion. At this time, the PA pressures were found to be acceptable, 14 millimeters mercury, with a PVRI of 1 Wood unit, and he underwent extracardiac fenestrated fontan completion. He presents to us now with effort dyspnea, deep central cyanosis that worsens with exercise. His weight is 36.6 kilograms. His saturation is 78% at rest and decreases to 72% odd with exercise. X-ray shows situs solitus levocardia with CT ratio of around 50%. Echocardiogram shows a well-functioning fontan circuit with a fenestration that shunts vigorously from the conduit to the atrium with a peak gradient of 20 and a mean gradient of 11 millimeters mercury, and adequate ventricular function. So he recently underwent a catheterization study to test balloon occlusion of the fontan fenestration. The balloon waist size measured 8 millimeters. On balloon occlusion, the PA pressure went up by a pressure of 3 millimeters mercury, and consequent rise in the aortic saturation was observed with balloon occlusion. We are planning today to do a fontan fenestration restriction using an atrial flow regulator device. Thank you.
Wow, I've never seen one of these before.
Okay. The story is this is a boy who has a fontan that is fenestrated, whose fontan pressures are 13 millimeters. The transpulmonary gradient is quite high, it's around 8 to 9, and he is more blue than what we desire. His saturations are around 78 to 79% in a resting state, and it worsens quite a lot on exercise. He's quite blue. So we again repeated a hemodynamics today. Show the angio. We show the angio live. When we occluded today, we got the same hemodynamics. The fontan pressures are 13 millimeters of mercury, and on occlusion it raises to 16. The atrial pressures are quite low. It's about 5. We are having a transpulmonary gradient of 8. Next picture. The waist of the balloon was measuring about 8 millimeters. It's a very compliant balloon. Next. Next picture. So this is the Fontan injection. We can appreciate that when we are injecting into the Fontan pathway, very less amount of the inferior vena cava blood reaches the lungs, and most of it gets diverted through the fenestration. We know that we cannot completely close the fenestration. However, we are thinking about reducing the size from 8 to 6. I'd like to show this device. Can you show the camera here?
Mm-hmm.
The-
Siva,
Yes.
this is Nick Haas from Germany.
Hi, Nikas.
Hi, greetings to India.
Yeah.
Wonderful case, and we have just done exactly the same thing what you want to do in a patient with the same circumstances, and we used a 4 millimeter hole. And at the end, our patient improved the saturation from the 70s at rest to the 90s at rest. And still with the 4 millimeter fenestration, I think you still have enough hole to allow decompression of the Fontan pathway. And a 6 millimeter may not, let's say, shrink this hole sufficiently. What do you think?
Yeah, I think so. I was thinking.
Well, I must say,
The problem about a 4 millimeter is if it closes off acutely, then we will be having a problem of acutely failing Fontan. Whereas,
It will not. You have a high pressure. Look, if you have a...
yeah, another option that I was thinking in my...
The patient will be warfarinized or anything like this?
Yeah, he's on warfarin. I was thinking...
The patient will be on anticoagulation.
Yes.
And you...
one at a time, guys.
Yes.
See,
Go, Shiva.
the question is whether 6 is like too large. What I am thinking now to do is, I am skeptic about 4. 4 is too small. I am planning to put a Prolene stitch around this waist and slightly restrict it to 5.
Don't do this. Don't do this.
But 4 closes off sometimes.
No. I mean, surgeons, yes, sometimes anything happens, but surgeons, when they use Fontan fenestration, usually a 4 millimeter is a pretty much standard in for the small kids. And you have a high pressure gradient between the Fontan pathway and the left side of, or the atrial side of the heart. And this high pressure gradient, in combination with the anticoagulation, and this patient should be, of course, anticoagulated in this kind of situation. From what I think and what I've seen, I think this is absolutely fine. And if you start now to manipulate a device which is completely new, I think you do harm to the device, and I think this is not a good approach, sorry to say.
So let me give you a little historical perspective here. Why is it that fenestrations are 4 millimeters? The reason is that when we first started doing fenestrated Fontans 22 years ago, we started out with 6 millimeter holes, and all of those patients were too blue. Then we went to 5 millimeter holes, and they were still too blue. And we settled on 4 millimeter holes after the first dozen patients. So I would agree, and if you think about it carefully, if you put in a 6 millimeter device and it's too big, you're now going to have to put a substantial amount of hardware in another umbrella to close it. Whereas if you put in a 4 millimeter device and it's too small, it's going to be very easy to get through the center of that device and open it with either a balloon or a stent. Me personally, I would agree that 4 millimeters is the safer way to go. But before we watch this, Allison has asked me to switch us back to the Frankfurt so we can see the ASD closure while people are figuring out what to do in Madras. Allison?
Alison, are you going to Frankfurt to see the ASD?
are going to Frankfurt.
Okay, okay, fine.
And finally, a final comment: if you use this nylon thing to shrink down the hole, you increase the diameter of the device, and thereby you increase the length of the device or the height of the device, and thereby you possibly increase the thrombogenicity. And this is another downside of this approach. You see that it's now much higher. So why don't you use the design, which is a flat design, 4 millimeters, instead of creating a new thing?
All right, I think that's enough nagging of the people in India. Let's go to Frankfurt.
Sure, we will wait for you.
Okay, we're now back in Chennai.
Yeah. So what we decided, what we debated was whether to use a 4 or a 6 or something in between. The experience with a 4 mm device, even for that matter, a 6 mm device, Dr. Joseph Vettukatil has observed thrombosis at the end of 3 to 4 months. As Dr. Locke was mentioning, if it is a 4 and if the patient gets into a trouble, it is always easier to put in a stent and try to open it out. However, if the whole event is going to happen at some remote area, then we will not have an access to this patient. This patient is actually coming from South Africa. He's a Sri Lankan who is living in South Africa and who is coming to India for a treatment. So I thought a lot, and I decided that I will go ahead with the original plan of putting in a 5 millimeter. So now let me show you the picture, like zoom in here, zoom in. So what I have done is I have taken one Prolene stitch, show that dilator. So I have taken it around 5 millimeter. So this is 5 millimeter, and I have made it a snug fit for a 5 millimeter. So now we are going to load the device into the sheath. I will do that now underwater. Now I am going to go with the deployment. So we have we are now loading the device onto the sheath. This is a 10 French sheath. So the device gets opened in the left atrium. And now we are pulling it back. And after getting a snug fit, we open the right side. I'm going to make an angiogram now. Contrast. Through the side arm of the delivery system, show the device on fast now. Come to RAO. Okay, that is end on. Go to on fast view. Yeah, give it cranial or caudal and get it perfect. The other direction, the other way. Yeah, enough. Make a mag of it. So what is happening is the Fontan pressures, show the side arm pressures. Show it AP. Check your zero of the transducer quickly. The transducer is giving a very bizarre reading, so I am just checking the zero of the transducer.
What pressure were you getting in the baffle? I can't see.
The values are around 13 millimeters of mercury. The Fontan pressures.
What is it now?
Hello?
What are the Fontan pressures reading now that you have the device deployed but not released?
Not released, and now we are having not much of elevation. It's somewhere around 13, 12 to 13. It's between the 10 and the 15 lines. Zero it once again, properly zero. It's the pressures are have not.
Well, excuse me.
When we made a complete balloon occlusion, the Fontan pressures went up to 16, 1.6. But now with this fenestration on, it is currently around 13. Show it in 25 scales.
So this is
small speed, smaller speed.
This is now a little bit of an active phase. And the reason it's an active phase is that you will get deposition of fibrin platelets around this device, which will progressively decrease the size in a semi-predictable way. I'm not surprised that the baffle pressure didn't go up, because the differences between too big and too small a hole are really quite small in this condition.
Yeah.
And I don't know that any of us here know what this baffle pressure will be a month from now or 6 months from now. But I don't think it'll be 13. I think it'll be higher than 13.
When he's awake.
But obviously, the most important number here is his aortic saturation. If his aortic saturation is above 88 or 89, that's about as good as you can hope for.
Yeah, we are looking at the aortic saturation now.
You won't know what that is for weeks or even months.
We are also looking at the aortic saturation. We just it was showing 90, 91, and we are waiting for a good trace. Show the aortic pressure now. Show the aortic pressure also. We can take one blood gas from the aorta. The aortic pressures are normal. In fact, marginally hypertensive. Can we have a good pulse oximeter trace? Can you put it on the other side so that it is? The aortic pressures.
Any comments from the audience here?
We are getting a blood gas
Sure.
analysis from the arterial line.
You have a question over here in the right front.
Hi, this is Ashish, Dr. Ashish from India, PDA Chandigarh. Hi, sir. Thank you for a brilliant case here. I have two questions for you. First, your experience regarding this atrial flow regulator and changing the aperture diameter previously. And second, in the condition like this where you, after closing, you get the PA pressure around 13 or 15, your opinion regarding complete occlusion of this fenestration.
I already mentioned a complete balloon occlusion resulted in a Fontan pressure going up to 16 millimeters of mercury, and the transpulmonary gradient was 8 to 9. We were not happy to close it completely. We feel that he may not tolerate a complete closure. Now about this partial closure, in fact, this is the first time I'm using this flow regulator on reducing the size of a Fontan fenestration. The device is available in 4 different sizes: 4 mm, 6 mm, 8 mm, and 10 mm. The 4 millimeter device, I have heard anecdotally that it closes off very soon. As Dr. Locke was pointing out, there is going to be some degree of fibrin deposition and maybe endothelialization from the left atrial side of the device. And I think the device may get little more smaller than 4, which might perpetuate a small thrombus formation within the device, and it may close off. So 4 was little smaller for me. 6, the actual fenestration was measuring around 8. So 6 will probably make it little smaller, but we wanted to have some fair amount of increase in the oxygen saturation. Right now, as I speak to you, the child is not on any supplemental oxygen. The saturations are 83%. It has marginally increased by about 5% compared to the pre-procedural, like at the beginning of the procedure. The Fontan pressures are not substantially elevated. It continues to remain at the same 13. He's, as it was pointed out to you earlier, he's already on 2 pulmonary vasodilators, sildenafil, bosentan, warfarin. So I don't want to make it too small, a fenestration.
Any other comments from the audience here? Here's something down here,
Yes,
front
this
left.
This is Nick again. We had this device placed in patients on compassionate care basis, and we had one patient with left heart problems, and we implanted this around about a year ago. This patient finally ended up having a cardiac transplant as scheduled, as planned, and when the heart was taken out 1 year later, we had the chance to have a look at this device 1 year after implantation. It was a 6 millimeter device, or a device with a 6 millimeter hole, and there was ingrowth.
Shiva, we're going to go back to CBC for echo, so are you going to release the device?
This patient was on warfarin too. So putting all this together, I think the likelihood that this will completely ingrow is not as big as if you would have an ASD device where everything, the flow is completely obstructed.
We're about to go back to Frankfurt, but the only comment I would like to make is that this is a brand new procedure. It's going to be unpredictable precisely how devices like this are going to behave. They're going to behave differently in low flow versus high flow situations. And the only way for the field to know how big a device like this should be is through a trial and error process. And I don't really think there's any other way to figure out how best to do this. Allison, can we go? But thank you very much for an extremely informative and very interesting case. So, I think it is likely that this device will find a place in the management of significant congenital heart disease. Thank you very much. Allison?
Okay, well, excuse me, just before going to Frankfurt, for those who do not have here, I'm here on the back, okay? Just for those who do not have that kind of device, is it possible to use a homemade fenestration? I mean, just opening the device with any dilator or things like that for those who do not have such kind of device?
Well, I did that quite a lot with the old Starflexes and CardioSeals. We probably put in 30 or 40 of those devices. I think it's harder to do with a wire mesh device. It's much easier to do with a device that's closes mostly with
Definitely
fabric.
smaller than what
And that's
it
a
is
very
originally.
successful technique.
I don't want to make it
But
very
I'm
small.
not sure
also.
they're available anymore.
Let it endothelialize slowly. Now,
Of course. Wait a second, I have to put on my blue glasses.
How come you don't have your black glasses on?
are we still alive? Still live? Hello, Alison?
Yes.
Contrast. Show the pressure. Huh? We'll give the same.
Hi, Shiva. That was a really nice case. We're going to be finishing this session, and then we'll come back
Okay,
to you
sure.
right away for the PDA closure.
Sure. We'll come back. Yeah, thank you.